السلام عليكم ورحمة الله وبركاته. موضوعنا النهاردة روماتيك فيفر. Acute rheumatic fever is an autoimmune consequence of pharyngeal infection, not skin infection, with group A beta hemolytic streptococci. Generalized inflammatory autoimmune response affecting brain, joint, skin, subcutaneous tissue, and the heart. Modified Dockett-Jones criteria form the basis of diagnosis of the condition. Grossly, acute rheumatic fever show pancreatitis, fibrinous pericarditis, myocarditis, endocarditis, valve vegetation. Microscopically characterized by ash of body which is pathognomonic, showing necrosis, macrophages, T lymphocytes, giant cell near a blood vessel. Supporting evidence that group A beta hemolytic streptococcal infection is responsible for acute rheumatic fever include about 66% of patients with an acute episode of rheumatic fever have a history of an upper respiratory tract infection several weeks before the attack. The peak age is from 6 to 15 years. Seasonal incidence of acute rheumatic fever closely parallel to those of group A beta hemolytic streptococcal infections. Patients with acute rheumatic fever almost always have serological evidence of recent group A beta hemolytic streptococcal infection, and their antibody titers are usually considerably higher than those in patients with group A beta hemolytic streptococcal infections without acute rheumatic fever. Antimicrobial therapy against group A beta hemolytic streptococcal infection prevents the initial episodes of acute rheumatic fever, and long-term continuous prophylaxis prevent the recurrence of acute rheumatic fever. What are the features suggestive of group A beta hemolytic streptococcal infection? Patients 5 to 15 years, presentation in winter or early spring, fever and headache, sudden onset of sore throat, nausea, vomiting, abdominal pain, pain with swallowing, beefy swollen red uvula and soft palate petechiae, donut lesions, tender enlarged anterior cervical lymph nodes, and tonsillopharyngeal erythema and exudation. The upper image to the left showing redness and swelling of throat and tonsils. The upper image to the right showing puffy swollen red uvula with soft palate petechiae denoting donut lesions. The lower right panel show tonsillopharyngeal erythema and exudate. What are the predisposing factors for acute rheumatic fever? Family history of rheumatic fever, low socioeconomic status including poverty, poor hygiene and medical deprivation, age from 6 to 15 years old. The incidence of rheumatic fever varies from 0.2 to 0.75 per 1,000 persons per year in school children age 5 to 15 years, and this was a governmental estimate in 2000. No pathognomonic clinical or laboratory finding for acute rheumatic fever. However, Dockett-Jones criteria in 1944 proposed guidelines to aid in diagnosis and to limit overdiagnosis. There are 5 major, 4 minor, and an absolute requirement for the evidence of recent group A beta hemolytic streptococcal infection, either microbiological or serological evidence. Jones criteria for the diagnosis of acute rheumatic fever include 2 major criteria or 1 major plus 2 minor criteria along with the absolute requirement. Major manifestations include carditis, polyarthritis, erythema marginatum, subcutaneous nodules and chorea. Minor manifestations include clinical features like fever and arthralgia, laboratory features like elevated acute phase reactants such as ESR and C-reactive protein and prolonged BR interval, plus supporting evidence of group A streptococcal infection like elevated or increasing streptococcal antibody titer, a history of within 45 days positive throat culture or rapid streptococcal antigen test or streptococcal sore throat or scarlet fever. First episode or recurrence with established heart disease, without established heart disease, can be diagnosed by 2 major criteria or 1 major plus 2 minor, along with the absolute requirement of group A streptococcal infection. However, recurrence with established heart disease require only 2 minor criteria and the absolute Arthritis is the earliest manifestation of acute rheumatic fever, and it's most common, occurring in 75% of patients with acute rheumatic fever. Correlate temporally with the peak anti-streptococcal antibody titer, and there is an inverse relationship between the severity of arthritis and the severity of cardiac involvement. Migratory polyarthritis involves large joints like knee, ankle, wrist, and elbows. Rheumatic joints are red, hot, swollen, tender, and friction of bed closes is uncomfortable. The pain can proceed and can appear to be disproportionate to the other findings. The joint involvement is characteristically migratory in nature. However, monoarticular arthritis is unusual unless anti-inflammatory therapy is initiated prematurely, supporting the progression of the migratory nature of polyarthritis. If a child with fever and arthritis is suspected of having acute rheumatic fever, withhold salicylates and observe for migratory progression. Also, a dramatic response to even small doses of salicylates is another characteristic feature of arthritis. Rheumatic arthritis is typically not deforming. Carditis. Carditis and chronic rheumatic heart disease is the most serious manifestation of acute rheumatic fever. Account for essentially all of the associated morbidity and mortality. Occurs in 50% of patients. Rheumatic carditis is pancarditis with active inflammation of myocardium, pericardium, and endocardium. Acute rheumatic carditis diagnosed by tachycardia out of proportion to fever and cardiac murmurs, with or without evidence of myocardial or pericardial. Carditis consists of either isolated mitral valvular disease or combined aortic and mitral valve disease. Valvular insufficiency is characteristic of both acute and convalescent stages of acute rheumatic fever. Mitral regurgitation, a high-pitched apical hollow systolic murmur radiating to the axilla. In patients with significant mitral regurgitation associated with an apical mid-diastolic murmur of relative mitral stenosis. Aortic insufficiency is a high-pitched decrescendo diastolic murmur at the upper left sternal border. Valvular stenosis appears several years or even decades after the acute illness. However, in developing countries where acute rheumatic fever often occurs at earlier age, mitral stenosis and aortic stenosis may develop in young children. Moderate to severe rheumatic carditis is characterized by cardiomegaly and congestive heart failure with hepatomegaly, peripheral and pulmonary edema. Myocarditis and or pericarditis without evidence of endocarditis is rarely due to rheumatic heart disease. Echocardiographic findings include pericardial effusion, decreased ventricular contractility, aortic and or mitral regurgitation. The major consequence of acute rheumatic carditis is chronic progressive valvular disease. The upper left panel showing during an episode of acute rheumatic fever, valve changes are minor and still able to regress. However, in the lower right panel, after recurrent episodes of acute rheumatic fever, thickening and shortening of subvalvular apparatus and chordal tendini with progression to permanent valve disease is evident. This X-ray shows cardiomegaly in the form of increased cardio. Also, this shows increased cardiothoracic ratio and cardiomegaly. In ECG, prolonged PR interval is pathognomonic. The P wave represents the atrial activity on ECG, and the QRS complex is the ventricular activity in ECG. Ideally, the PR interval is less than 1 large square. However, it's considered to be prolonged if it is more than 1 large square. Also, complete third-degree AV block may occur, and it's characterized by atrioventricular dissociation, diagnosed by a variable PR interval, which must be in normal subjects to be fixed, and not every B is followed by QRS complex. Finally, a sore throat can lead to a broken heart. Sydenham Sandvitas dance or Sydenham chorea 10 to 15% in patients with acute rheumatic fever, often in prepubertal girls 8 to 12 years. A long latency period 1 to 6 months between the streptococcal pharyngitis and the onset of chorea. A neuropsychiatric disorder with neurological signs, colic movements, hypotonia, psychiatric signs, emotional liability, hyperactivity, separation anxiety, obsessions, and convulsions. Begin with emotional liability and personality changes represented with poor school performance. Persist for 1 to 4 weeks and then replaced by characteristic spontaneous purposeless movement of chorea, which lasts for 4 to 8 months, followed by motor weakness. Exacerbation by stress and disappearing with sleep are characteristic. Elevated titers of anti-neuronal antibodies against basal ganglion tissue have been found in over 90% of patients. Clinical maneuvers to elicit features of chorea include demonstration of milkmaid grip, irregular contraction of the muscles of the hand while squeezing the examiner's finger, spooning and pronation of the hand when the patient's arms are extended, whirling, darting movement of the tongue upon protrusion, examination of handwriting to evaluate fine motor movement. Diagnosis based on clinical finding with supportive evidence of group A beta-hemolytic streptococcal antibodies. In patients with long latent period, antibody levels may have declined to normal. Subclinical carditis is present in 30%. Although acute illness is distressing, chorea rarely, if ever, lead to permanent neurological sequelae. Erythema marginatum. A rare in less than 3% of patients with acute rheumatic fever, but characteristic rash of acute rheumatic fever. It consists of erythematous, serpiginous macular lesions with pale center that are not pruritic. It occurs primarily on the trunk and extremities, not on the face, and it can be accentuated by warming the skin. And this figure shows erythema marginatum on the trunk and the back of the baby. Subcutaneous nodules. A rare in less than 1% of patients with acute rheumatic fever finding. Consist of firm nodules approximately 1 cm in diameter along the extensor surface of tendons near bony prominences. A correlation between the presence of these nodules and significant rheumatic heart disease, and these are subcutaneous nodules. Minor clinical, like arthralgia in absence of polyarthritis, fever, typically temperature more than 37.2 degrees centigrade, laboratory minor manifestation, elevated acute phase reactant like C-reactive protein, ESR, polymorph nuclear leukocytosis, and ECG show prolonged PR interval first degree heart failure. Essential criteria. An absolute requirement for diagnosis of acute rheumatic fever is the supporting evidence of recent group A beta-hemolytic streptococcal infection. The hallmark of gas sore throat include high fever, tender anterior cervical lymph nodes, close contact with infected person, strawberry tongue, petechiae on palate, excoriated nerves in infant, tonsillar exudates in older children, and abdominal pain. The gold standard is positive throat culture. Acute traumatic fever typically develop 2 to 4 weeks after an acute episode of group A beta hemolytic streptococcal pharyngitis, at a time when the clinical findings of pharyngitis are no longer present. Only 10 to 20% of throat culture or rapid streptococcal antigen test results are positive. Therefore, evidence of an antecedent group A beta hemolytic streptococcal infection is usually based on elevated or increasing serum anti-streptococcal antibody titers. Like ASO, well standardized, elevated in 80% of patients with acute traumatic fever. An ASO titer more than 333 TODS unit in children, more than 250 TODS unit in adult are considered elevated. Anti-deoxyribonuclease B titer more than 240 TOD unit in children and 120 TOD unit in adult considered. Slide agglutination test, streptozyme test, detect antibodies against 5 different group A beta hemolytic streptococcal antigen. Rapid, relatively simple to perform, and widely available. However, less standardized, less reproducible than other tests, and shouldn't be used as a diagnostic test for evidence of an antecedent gas infection. Single antibody titer measured 80 to 85% have an elevated titer. However, if 3 different antibody titers are measured, 95 to 100% have an elevation. Therefore, in suspected acute traumatic fever clinically, perform multiple antibody tests. Diagnosis of acute traumatic fever shouldn't be made in patients with elevated or increasing streptococcal antibody titers who don't fulfill the Jones criteria. Differential diagnosis for arthritis, rheumatoid arthritis, reactive arthritis, cellular sickness, sickle cell disease, malignancy, systemic lupus, Lyme disease, and gonococcal infection. For carditis, viral myocarditis, viral pericarditis, infected endocarditis, Kawasaki disease, congenital heart disease, mitral valve collapse, and innocent murmurs. For chorea, Huntington chorea, Wilson disease, systemic lupus, cerebral palsy, tics, and hyperactivity. Patient with infected endocarditis present with both joint and cardiac manifestation and may be confused with acute traumatic fever. These patients can usually be distinguished from acute traumatic fever patient by blood culture and the presence of associated findings like hematuria, splenomegaly, and splinter hemorrhage, which are pathognomonic for infected endocarditis. Treatment: bed rest and start antibiotic therapy, 10 days of oral administered penicillin or erythromycin or a single intramuscular injection of benzazine penicillin. Afterwards, the patient should be started on long-term antibiotic prophylaxis for secondary prevention. Anti-inflammatory therapy, including salicylates and corticosteroids, shouldn't be used if arthralgia or atypical arthritis is the only clinical manifestation of the presumed acute traumatic fever. Acetaminophen can be used. Patient with typical migratory polyarthritis with carditis without cardiomegaly or congestive heart failure, treatment with oral salicylates, starting with 100 mg per kilogram per day in 4 divided doses per oral for 3 to 5 days, followed by reducing the dose to 75 mg per kilogram per day in 4 divided doses per oral for 4 to 8 weeks. Patient with carditis with cardiomegaly or congestive heart failure, treatment should be with corticosteroids. Prednisone 2 mg per kilogram per day in 4 divided doses for 2 to 6 weeks, followed by tapering in the dose that reduce the dose by 5 milligram from the daily dose every 2 to 3 days. At the beginning of tapering of prednisone dose, aspirin should be started at 75 milligram per kilogram per day in 4 divided doses to complete 12 weeks of therapy. Supportive therapy for patients with moderate to severe carditis include digoxin, fluid and salt restriction, diuretics and oxygen. The cardiac toxicity of digoxin is enhanced with myocarditis. Sydenham chorea occur after resolution of acute phase of the disease, so the anti-inflammatory agents are usually not indicated. Treatment includes sedatives like phenobarbital is the drug of choice. If phenobarbital is ineffective, then haloperidol or chlorpromazine should be initiated, plus long-term antibiotic prophylaxis for secondary prevention. Strep throat causes rheumatic fever, causes rheumatic heart disease, which is a serious medical problem. So, what to do? Sore throat must be prevented. Either primary prevention for patients with group A streptococcal infection without rheumatic fever to prevent the occurrence of the first attack of rheumatic fever. 10-day course of penicillin therapy. You know that about 30% of patients with acute rheumatic fever don't recall a preceding episode of pharyngitis. Secondary prevention is directed to preventing acute group A beta hemolytic streptococcal pharyngitis in patients at substantial risk of recurrent acute rheumatic fever. Secondary prevention methods of prophylaxis include benzazine penicillin. This is long-acting penicillin, 600,000 units for children less than 27 kg, 1.2 million units for children more than 27 kg every 3 to 4 weeks intramuscular. Or oral penicillin like penicillin V, 250 mg twice per day oral. For patients who are allergic to penicillin, macrolide and azalide can be used oral route. Who should receive prophylaxis? Patients with documented history of rheumatic fever, including those with isolated chorea, those without evidence of rheumatic heart disease must receive prophylaxis. For how long? In rheumatic fever without carditis, at least 5 years or until age of 21, whichever is longer. In rheumatic fever with carditis, but without residual heart disease, at least 10 years or well into adulthood, whichever is longer. In rheumatic fever with carditis and residual heart disease, at least 10 years since the last episode, or until the age of 40, sometimes lifelong. And this is a summary for acute rheumatic fever. You can review what we have said. My take-home message. Sometimes we face very difficult times. All what we need, just never give up. And thank you.